I'm Tim Klein. I am a hospitalist and internal medicine doctor here at Hardin Medical Center. I serve as the chief medical officer here. I also serve as the director of the wound care clinic and am an attending physician with Dr. Qualls on the hospitalist service. A hospitalist is a specialty of medicine in which a physician solely practices in an acute or critical care setting in a hospital. It can be either family practice, internal medicine, or subspecialties including general surgery, obstetrics and gynecology, pediatrics, and other areas, specifically in large metropolitan areas. But primarily when you think of a hospitalist, it's either an internal medicine doctor or family practice physician that manages patients from the time that they're admitted through the emergency room until the time they are discharged. A hospitalist serves as an extension from those patients' primary care provider in managing those patients safely and thoroughly throughout their hospital experience. The hospitalist coordinates the care of the patient while they're in the hospital, utilizing resources available, including consultations by other specialists or subspecialists, and in fact, even using telemedicine opportunities to include specialists that are from metropolitan areas that are also on the staff. These physicians then in turn discuss their opinions and findings with the hospitalist and provide formal reports that go into the medical record. But that's just one of numerous examples that will be forthcoming in the future in medicine, particularly in hospital medicine. Prior to the hospitalist model, the primary care physician would often and usually make rounds on their hospitalized patient in the morning, then returning back to their office for their day's work of seeing patients there. Then after the office, if necessary, would come back to the hospital. As the hospitalist model evolved throughout the 1990s and has progressed during that time period, the hospitalist now serves as an extension to that primary care physician in the care of their patient directly. That allows the primary care physician to be in their office more frequently and for longer periods of time to address the issues of those patients that are there. It also allows the hospitalist to bring their expertise, knowledge, and experience to acute and critical care patients in the hospital. Communication is available with the primary care physician on an as-needed basis, either directly by phone or certainly when the patient is discharged, the complete summary of the hospitalization is provided to the primary care physician. As a hospitalist, most commonly we are called by the emergency room physician after the patient presents for evaluation of symptoms, and a decision is made as to whether or not the patient needs to be admitted to the hospital or can be returned back to the community with medical management, or in approximately 8% of the time transferred to a higher level of care in a metropolitan area such as Jackson, Nashville, Florence, or even Corinth. If the patient is determined to be appropriate for admission here at Hardin Medical Center, the hospitalist then assumes primary and total management and control of that patient's medical needs throughout the acute hospitalization. The hospitalist sees the patient on at least a daily basis and oftentimes more frequently than that as the need arises. All care is provided to that patient, both not only with their acute issues, but also their chronic medical problems. The average hospital patient has at least 5 to 7 chronic medical issues and at least 5 to 7 chronic medications that they're usually on. These are interposed with the acute issue at hand. There is reassessment of the condition and moving towards resolution, not only with diagnosis and then treatment for that condition. On rare instances, there are times where the complications arise and the patient may need to be transferred to a higher level of care. It is the hospitalist's responsibility to coordinate that care at the direction of the family and the patient as to the hospital of their choice. And then we make sure that that patient gets transferred accordingly when necessary. As a hospitalist, the main thing that I have enjoyed is the acute nature of the situation, the ability to determine the differential diagnosis, meaning specifically the possibilities of what could have caused the symptoms of the presentation, and then determining what's the best path of treatment. Primarily, that's done in real time. It's done over a matter of 24 to 48 hours as far as the initial diagnostic evaluation and installation of a treatment plan, compared to outpatient medicine in a primary care setting, where oftentimes these conditions are considered, but then laboratory tests are ordered, and it may take a day or two for those to come back. Diagnostic radiology studies have to be scheduled, and everything is done on a delayed basis. Whereas as a hospitalist, it's very quick, it's goal-oriented, it's task-oriented, to quickly make those decisions. And my personality is such that I like making decisions quickly, effectively, and affirmatively in a patient's care.